Hello again for those who saw me this morning. Ayman, Professor Ayman, thank you for the invitation and for the nice introduction. Um, this was Professor Fakri in Hanover last week, where I was the president of the German Society meeting, and we had the first Egypt-German session to be continued next year. I am to talk about standardization for best practice. And I had a look in Wikipedia. What is best practice? It's a method or technique that has been generally accepted as superior to other known alternatives because it often produces results that are superior to those achieved by other means or because it was become of standard way of doing things. In phlebology, we have so many different ways of doing things that standardization is so difficult because best practice treating veins, we have conservative treatments with compression, ablative treatments, surgery, high ligation stripping, endoluminal catheter-guided treatments, ultrasound-guided foam sclerotherapy, saphenous vein sparing treatments. I have learned that also in Egypt they are common, like Chiva or Aswal. And if we want to compare the results of all these strategies or treatment options, we have to be sure that the preoperative exploration had been the same. So we measure our results in clinical disappearance of veins and symptoms and in recurrence rates. The most frequent recurrence place is the saphenofemoral junction. So I would like to represent why the standardized acceleration of the junction is so important. You see here the deep, the mouse isn't moving. Okay, the common femoral vein, the artery, the great saphenous vein and the tributaries, with the terminal valve, the preterminal valve and the femoral valve, and the cranial tributaries and the medial tributaries, and all these compose the saphenofemoral junction. And there are so many variations, and there are also further veins that can be refluxed, not only the saphenous vein, but also the anterior accessory saphenous vein. So this is, excuse me, the air conditioning kills me. We have one situation with competent valves, which looks like this, blood flowing upstairs and the tributaries draining into the great saphenous vein. If we have a reflux, the question is from where? This can be from the deep vein, which is called axial reflux with terminal and preterminal valve incompetent. And we have seen this more extensively this morning. You have in the systole, you have an anterograde flow in the saphenous vein to the deep vein, and in diastole, you have a reflux. And this can be measured in the very ostium level with toe elevation and toe relaxation. And you see an anterograde flow in the systole and a retrograde flow in diastole. And you have to measure it really here to assess the terminal valve. But we have refluxes in other situations like competent terminal valve and reflux from a groin tributary and an anterograde flow in this terminal valve. And this is the very important difference between this and this situation. It is a non-axial reflux or also paraosteal reflux. You see in systole the same situation than in the other with the terminal valve incompetency, but in diastole there is no reflux from here. It is only from the tributary of the groin. Why is this so important? The just published clinical practice guideline from the European Society of Vascular Surgery under the auspices of Marianne de Mezener highlight that 27% of the neovascularization and recurrences in the groin, a pelvic reflux source is found. Sorry, as to be the reason for the recurrence. So if there are different recurrence sources preoperatively and 27% of the recurrences come from the pelvic reflux, could it be that we should treat the pelvic reflux differently from other refluxes in the first way? These one are those with a pelvic reflux source. And I am not approving with this to say that we have to coil the ovarian vein in every person of this 20% of people having pelvic reflux, but we could, if it's a fascial foam then, or we could inform the patients that this could be a problem in the future, and we could treat them according to this finding, like I am going to show you. Since 2006, I'm claiming to examine the exact reflux source in clinical trials, but apart from Jiva studies, nobody took this into account. Even not the new synchronous study we are doing in Germany to look if we should ablate or not ablate the anterior accessory vein when we do a saphenous vein ablation. They did not take into account in a long-lasting prospective study if preoperatively you have this or this condition. And this is a shame in my eyes because we only will know half of the truth. To those who were here this morning, they have seen this also, but just to emphasize, this is the common femoral vein, great saphenous vein tributary. In systole, you have an anterograde flow. In diastole, you have no reflux from the deep vein, but from the tributary of the groin. So if you look at this and you think about closing the great saphenous vein here, below the influx of the tributary of the groin, this one could drain to the deep vein and there would be no need of recurrency. If, in my eyes, this situation would be treated with high ligation and stripping, this reflux from the pelvis, which is not a pelvic problem but just a draining from pelvic blood after pregnancies, for example, will have no way to drain to the deep vein and will form neovascularizations. But I can't prove this because no studies have been performed. Again, this is the difference between a reflux from the deep vein or from the tributary. Of course, closing here is no point in this case because the terminal valve is competent. So in these cases, closing below the preterminal valve would be the best point. In this case, you can imagine that if you leave the stump and close only here, it could be a new escape to the accessory anterior. But again, we can only guess, we can't know because this isn't considered in any study. So on the first point, we have to find out and document where the reflux comes from. Axial, from the deep vein, cranial, or both, because we often have also the situation. And the German group investigated this, also with the combination to where the reflux comes, into the great saphenous vein, into the anterior accessory, or into both. The standard is, of course, standing position. You have to look for the morphology in longitudinal cross-section. You use the color duplex to find the source and the PV mode to document the findings. You have to know at the end of the investigation the source of the reflux, the path of the reflux, and of course other anatomical findings like post-thrombotic changes, current thrombotic changes, lymph node alterations, and so on. A group from Jena from Germany made a large study on 2019 patients that were scheduled for surgery, not in a population, but in the surgical theater. And they divided them into 4 groups depending on the origin, which was axial reflux in 66%, both axial and cranial in 8%, cranial reflux, this means the terminal valve was competent in 21%, and the distal, like over a perforator, was called 0 and was in 3.5%. You don't have to know this table, but you have to look. They put the reflux source here, the reflux source on this side, and the drainage path on this side. And when you think of varicose veins, you always think, I'm sure, of this one coming from the deep vein and going to the saphenous vein. This one. But this one was found only in half of the patients. All the others had variations of this, and I think this is very important because this situation is the one we use for the studies, but this represents only half of our patients. The one draining to the anterior accessory was only 6% because in this office you have a wonderful Dr. Zollmann, female, the Christine Zollmann, who does wonderful foam sclerotherapy, and most of the accessory veins were foamed. So if you ask me, in a normal phlebologic office, you will find more. Okay, you will find more than 6% accessory anterior saphenous vein. Type C, cranial reflux, overall 21%, 50% draining into the great saphenous vein. So if you don't know what you treat, I mean, not you, but if you read the studies and you don't know what has been treated there, you cannot evaluate your or the study findings. The recurrence after high liganded and stripping with preoperative cranial reflux might result in this neovascularization because the pelvic reflux is cut in the middle of the way and has no more a drainage. The reflux into the anterior accessory vein after endoluminal therapy with preoperative incompetent terminal valve is a possible path for the still existing pressure in the stump. So this is all possibly because axial reflux possibly is best treated closing the saphenofemoral junction. Cranial reflux is possibly best treated closing the great saphenous vein distal the preterminal valve. This is pure logic, but nobody can answer the question because up to date no study has documented these preoperative findings to compare them with the results. And so please, at least when starting a new study, take into account the reflux paths in the rejoin region in the study protocol. And in your office, if you treat patients, please take into account what you are seeing before so that you can improve the treatment and best explain the patient what has to be done. Of course, you can, this is all explained, and I thank you so much for the attention.